Good evening, everyone. This is Dr. Vijay Chamble. I am working as a head medical office with Urihk Pharmaceutical Mumbai. I take this opportunity to welcome all the delegates for this webinar, which we are conducting on the topic of use of immunomodulators in critical illness. Also, at the same time, I like to welcome all our faculties, the eminent faculties from Chennai for this today's webinar. We have blessed to have Dr. Dedipya Deva Prasad, who will be moderating the entire session. Dr. Dedipya Deva Prasad is a consultant, the critical care medicine specialist, and he is the coordinator of entire critical care unit at Apollo Multispecialty Hospital, Chennai. So without wasting too much of time, I kindly request Dr. Dedipya sir to take over the session and guide us throughout the session. Dr. Dedipya sir, the session is all yours.
Thank you. Good evening and welcome to all our participants. Even in this pandemic, when you're all very busy, nice of you to have logged in, and nice of this new company to come in and invite all of us for this webinar. And thanks, Dr. Vijay and the support team for putting it together. So we all know that we are going to talk about immunomodulation in sepsis, ARDS, and with COVID-19. And I have the pleasure of having a distinguished faculty with me, two of them who would be speakers and two of them who will join as co-panelists. First of all, I have the pleasure of inviting Dr. Pannaya Vanamurthy, who is the Associate Director and Senior Consultant in the MGM Healthcare. He is in charge of neuroanesthesia and neurocritical care, and he's also the Secretary of the Indian Society of then we would have Dr. Chakravarti Alapati, who will be following him. Is the head of emergency medicine and critical care in Bilrath Hospitals. And my two co-panelists would be Dr. Badri Narayanan, who's the head of critical care medicine in Hindu Mission Hospital, Tambram, and Dr. Rohit, who has had a stint in the UK and has returned to be in India. And he is with the Apollo Specialty Hospitals at Chennai. So today we are going to talk about immunomodulators, and let me set the tone for immunomodulation in sepsis. So if you look at definition of sepsis, we all know that in 1991, when sepsis was first defined, they just simply defined it as organ dysfunction in response to an infection because of a systemic inflammatory response. There again, what was happened was they just expanded the definition to include newer modalities of how to identify organ dysfunction. So until sepsis 3 came, we never paid attention to immune dysregulation. So now if you look back at the sepsis 3 definition, you'll understand that sepsis 3 defines a sepsis as altered or dysregulated post-immune response leading to organ dysfunction in response to an infection. So until sepsis 3, dysregulated post-immune response or a immune modulatory need for a response in sepsis was actually not emphasized upon. And remember that this definition has come in only in the last 3 to 4 years. And therefore, we don't understand immunomodulation as we should. Now we know that there are a lot of immunomodulatory therapies. Because we have not understood the immunobiology of sepsis very much, I don't think so we have focused much on the immunomodulatory therapy as well. To get you focus in point, we all understand that we all use dexamethasone for COVID-19. And why do we use dexamethasone? Because we know that it has got a mortality benefit. If you look at the biological plausibility of why we are having dexamethasone in COVID-19, you understand that it is possibly because of its immunomodulatory effect. Now forget COVID-19, let's go back to traditionally how we used to treat our patients with sepsis. We all know that we do use hydrocortisone at a dose of 200 milligrams per day for patients with septic shock. Now, if you look back, we know that we can use hydrocortisone for patients with septic shock. And why did we use it? We all thought we used it because in sepsis, you have a relative adrenergic insufficiency. And therefore, when we use it in patients with septic shock, you would have a better response. But this is possibly not a true reflection, because we know that even among the ACTH responders or the ACTH non-responders, in both we find that use of hydrocortisone is essential. And therefore, we no longer now test for the ACTR responsiveness. And therefore, that is possibly not the reason. Maybe the missed biological plausibility of hydrocortisone being beneficial in patients with sepsis was possibly its immunomodulatory effect. I'm just saying this to go back and reflect upon what we have not been looking at sepsis in the past because we have not understood the definition of sepsis as we should. Now, in the context of COVID-19, where dexamethasone being a primary agent for improving mortality, probably, and knowing the new definition of sepsis, probably we'll have to pay a lot of attention to the immunobiology of sepsis and look at the different immunomodulatory strategies that are available. And therefore, it is very important and exciting to listen to us two speakers. First, I'm going to introduce and welcome Dr. Ponaya. I've already introduced him, so I'm going to welcome Dr. Ponaya, who will be talking about immunomodulatory effect in response to sepsis and ARDS. And then we'll have Dr. Chakravarti to be talking about immunomodulatory therapies in response to COVID-19. And then we will have a panel discussion. So first, I'm going to ask Dr. Ponaya to start off with this presentation, and then it will be followed by Dr. Chakravarti. Thank you. Handing over to Dr. Ponaya.
Thank you, Dr. Deepya, for your kind introduction. So as you very well highlighted, the role of immunomodulation or the role of immune dysregulation in sepsis and ARDS, the main killers in critical care, has been well emphasized by you. So let me share my screen and start my presentation. So if you all could see my screen. Right.
Yes, sir. Yes, sir. We can see your screen.
Like our moderator pointed, the immune dysregulation, as we all know, has become the cornerstone in the management of sepsis, apart from resuscitation, maintaining the blood pressure, and giving appropriate antibiotics and source control. This is one thing which we target early. If we target early, then there is a potential chance of increasing the mortality benefit. So with respect to ARDS and sepsis, I'll be touching upon the immune regulation, the pathophysiology, and the therapeutic options available at present. So what happens in a critically ill patient? There is altered immunity. And immune dysfunction is very common, which directly affects the morbidity as well as the mortality. However, it's frequently overlooked. Why? Because unlike infection, it's a bit complex. The derangements are complex. There are various mediators which are involved, and different patients present with different manifestations. Also, we don't have that tool, that one tool which can say that this is it. We rely on various biomarkers, including CRP, procals, and the numerical distribution of leukocytes and things like that. But nothing has been proven as a gold standard or that's the thing. We need to always combine these markers along with the clinical presentation and the severity of the illness to get to a conclusion of how dysfunctional the immune system is and when to intervene and which patient to intervene and who will benefit and who may not benefit. That's very crucial, because if we start applying this therapy blindly for all the patients, then we get a negative outcome, and that becomes a standard, and we fail to use these medications in potential patients where it could be beneficial. So what is immune activation? It includes several components of the immune system. First is the physical barrier to tissue invasion itself is an immune activation. An innate response system, which is mobilized within minutes of a new threat. And there is an adaptive component, which requires, of course, more time for activation. But once activated, has specificity and memory. Each of these elements further are altered in critically ill patient. So what happens is there is an increase in vulnerability to infection and to the systemic consequences of a dysfunctional defense response system. And that's very important. And that's where we sometimes our therapies fail. In spite of targeting the infection and source control, When we fail to manage the systemic consequences of a dysfunctional defense response, then the therapy fails and will end up in poor outcomes. So patient with critical illness respond differently to injury. For example, a patient who may undergo a pronounced inflammatory phase characterized by increased production of TNF, interleukins, interferons, and IL-12, whereas some other patient may enter a persisting phase of injury-associated immune suppression, which is characterized by increased production of Th2 cytokines like IL-10 and IL-6. Both ways it is possible. There could be an intense inflammatory phase, or there could be an immune depressive phase. So the cytokine storm, the more fascinated terminology now, thanks to COVID, which has been existing for quite some time, but it's become more popular, this terminology. The immune system's response to infection or injury, which we have been seeing in so many insults, so many injuries, and so many diseases, it's not new. It's nothing but the interaction between the innate immune cells and the exogenous or endogenous molecules, which is pathogen driven. So what happens is there's an innate immune cell activation with upregulation of cellular functions. There are phagocytosis which are happening. There is intracellular killing, antigen presentation happening, intense cytokine release, pro-inflammatory mediators like TNF, IL-1, acute phase reaction promoter IL-6, and exaggerated and concurrent pro and anti-inflammatory response, which results in the intense cytokine storm and patient becomes so unstable. So uncontrolled cytokine release, there's no control mechanism in this, which links all. So what happens is whether it could be a lung infection or a lung injury, whether it could be an acute pancreatitis or an acute abdomen, a major surgery, major trauma, massive blood loss, burns, everything results in the final common pathway of an uncontrolled cytokine release, which predisposes the patient to ARDS, sepsis, and when improperly controlled results in multiple organ dysfunction, circulatory failure, and finally refractory shock where we are not able to do anything, and we land up in a poor outcome. So let's talk about sepsis and ARDS. So the sequelae of immune dysfunction is loss of immune regulation combined with shock, infection, inflammation, and or tissue ischemia, which results in sepsis, septic shock, DIC, coagulopathy, multiple organ dysfunction, other complication, ultimately a poorer outcome. So sepsis. So moderator already described the definition of sepsis has changed, and there has been an intense focus on the immune dysfunction in sepsis. So when there is an immune dysregulation, or when the body's immunity goes against us, then that is the sepsis. And there are innate immune system in sepsis, there are adaptive immune response in sepsis, which already enumerated. And accordingly, there are increased levels of pro-inflammatory cytokines, increased levels of anti-inflammatory cytokines, neutrophils. And then in adaptive immune response in sepsis, there is decreased monocyte expression, reduced number of circulating dendritic cells, reduced number of dendritic cells in the spleen, increased apoptosis of lymphocytes, increased response to T cell independent antigen. All these things happen. It's a complex pathway. So that's why dealing with this also becomes complex. And there is no one molecule which can be a gold standard in any one patient. So immune dysregulation, as it was emphasized in the beginning also, it's important. It's the important component of sepsis pathophysiology. And when it's failed to control in the initial stage, then the patient progresses in for septic shock, refractory shock, and multiple organ dysfunction. Simultaneous inflammatory and anti-inflammatory response driven by dysfunctional innate and suppressive adaptive immunity results in sepsis-induced organ dysfunction and poorer outcomes. So in ARDS, as you all know, the pathogenesis of ARDS is multifactorial. and it involves diverse immune cells of both the innate and adaptive immune system that mediates the propagation of lung injury triggered by an insult. It could be because of a transfusion or a pancreatitis, drug overdose, pneumonia, aspiration, sepsis, trauma, anything which triggers. And in the multifactorial fashion, the other immune system gets activated and it results in a profound ARDS. It's a bit complex. It involves at the level of the alveolar level. And finally, what happens is pulmonary edema and decrease in gas exchange. It increases the alveolar capillary permeability. There is endothelial damage, there is epithelial damage, and finally results in refractory ARDS when our lung protective strategies and other therapy fail to heal the immune dysregulation. So, having known this as an important component of the pathogenesis of both the sepsis and ARDS, what should be the therapeutic approach apart from the standard of care what we give? So the focused management of sepsis is early resuscitation, early application of vasopressors, cultures, and the identification of source and early appropriate antibiotics or early emphoric antibiotics and tailored to the cultures. We need to change it to appropriate antibiotics. Promptly measure the supporting or failing organs. That's very crucial. This is the basic standard of care. And in acute ARDS, you know that there is a rapidly progressing respiratory failure, and the hospital mortality could be as high as 40%, although it's not always so. And we need to have therapies for this devastating clinical condition apart from the standard of care. So what are the immunomodulated therapies which can be applied in sepsis and in ARDS? So the aim of the immunomodulated therapies and strategies in sepsis and ARDS reinstate a balanced immune response to infection, decrease excessive immune studied potential therapy for both early and late phase ARDS. Potential benefit includes due to suppression of pro-inflammatory cytokine response, and there are potential risks also. So corticosteroid therapy, which is a very commonly used therapy as well as studied in detail in several studies. As we all know, in sepsis, we are using up to 200 milligrams per day as a standard of care. When we have to apply more than one vasopressor, our patient is not promptly responding to fluid resuscitation, and the dose of vasopressors is increasing. Although there are a lot of studies which are for and against in sepsis, although in septic shock, most of the studies are in favor of shock not responding to initial fluid resuscitation and vasoactive agents. And the other common thing, some people like it and some people hate it, although it is being used commonly, and many are started using this hydrocot, ascorbic acid, and thiamine therapy, which is claimed to be a promising immunomodulatory treatment with a dose as high as 6 grams of ascorbic acid. Even 12 grams has been used nowadays in COVID. Thiamine with 400 milligram per day, hydrocot of 200 milligram per day. There is an impressive reduction in organ injury and mortality in septic patients when compared to matched controls. Although the studies are promising, we need still high quality trials to call it as a standard of care. So we'll know the results in coming years. The other molecule, ulinastatin. We all know that ulinastatin is a serine proteases inhibitor, which are serine proteases are involved in systemic inflammation and cell apoptosis. It's a broad spectrum serine protease inhibitor. It's found in human urine, blood, and other tissues. It acts as multiple levels. It has potent antioxidant and anti-inflammatory effects. It's been approved in India from the year 2013. So mostly it was used in acute pancreatitis. So the mechanism was the deactivation of chain reaction of pancreatic enzymes such as trypsin and the chymotrypsin, lipase, amylase, elastase, and carboxypeptidase. It also suppress the activation of polymorphonuclear leukocytosis in the multiple organ dysfunction syndrome. In sepsis, The mechanism could be inhibition of various serine proteases such as trypsin, thrombin, chymotrypsin, kallikrein, plasmin, elastase, and cathepsin. So, like this molecule has a potential to act in various stages of immune dysregulation. And there are studies and there are some meta-analyses to show that ulanastatin improves the prognosis in sepsis and septic shock. And in this meta-analysis of 13 RCTs and 2 prospective studies, including 1,300 odd patients with sepsis, septic shock, and severe sepsis, which was previously called, it has been shown to significantly decrease in all-cause mortality, decrease in Apache-2 score, decrease in MODS, multiple organ dysfunction incidence, serum IL-6 levels, and tumor necrosis factor alpha. And there is significant increase in IL-6. And there, although there was no significant difference in outcomes. In ARDS as well, a meta-analysis showed a reduced mortality, a decreasing ventilator-associated pneumonia rate, shortening duration of mechanical ventilation, and reduced length of ICU stay. A phase 2 trial of ARDS treated with ulanostatin showed improved lung oxygenation and function. In addition to this, there is another thymosin alpha 1, which is an endogenous 28 amino acid peptide. It's mainly secreted by thymus. It acts as an immune modulator, exerting greater biological influence in activating and regulating the functions of the immune system. The efficacy of thymosin alpha 1 for severe sepsis, which was studied in a multi-center single-bay randomized and controlled trial. They performed a trial in the 6 tertiary teaching hospitals in the China. The conclusion was that the mortalities from any cause within 28 days in the thymosin alpha group, alpha 1 group and control group were 26% and 35% respectively, with a marginal p-value. So still we need more data on this. Although the combination therapy with thymosin alpha and ulanastatin has been shown to improve the mortality benefit. So the other potential therapies in sepsis, which has been debated, which has been studied, but still nothing is gold standard or the standard of care, or the intravenous immunoglobulin therapy, Sepsivac, we all know, granulocyte macrophage colony stimulating factor, interferon gamma alpha, cytosorb therapy, which has been a bit promising, but although it needs all the dialysis and it's although theoretically looks very attractive. Therapeutic plasma has changed and multipotent mesenchymal stem cells. So these are all the potential therapies in sepsis. So to conclude my talk, the current evidence indicates targeting immune modulation, which will improve the prognosis in severe sepsis and ARDS. Timing and choice of immunomodulator can be the deciding factors in the outcome for severe cases, which still we are finding to figure it out, which is the best and which will be suiting for the best patient. Maybe we need to employ a precision medicine strategy and choose the molecule accordingly. Targeting immune modulation to prevent cytokine storm with treatments such as ulanastatin can be beneficial early in the course of sepsis. Although the data are there, still we need more data on this. Steroids and ulanastatin have potential for improving mortality outcomes in ARDS patients. Promising results with these agents suggest their potential to be integrated into the routine management of patients with ARDS sepsis, where we can improve the clinical outcomes. Thymosin alpha is approved in India for other viral infections like hepatitis B and C, and there are studies showing its benefit in the management of sepsis. Ulanastatin, as we all know, was approved by the DCGI for sepsis and acute pancreatitis in 2018 and has been used for the management of these critical conditions and other conditions as well. So with this, I conclude my talk and I'll give back to the moderator for him to take the session forward. Thank you.
Thank you, Dr. Pranaya. That was a very crisp presentation, and we really loved it the way it was done. I think just to summarize what you've already done for the audience, you just to take us through the immunobiology of sepsis and also how it works in ARDS. We talked about the different molecules involved, the cells that are involved, the monocytes and the neutrophils and the lymphocytes, how they're altered and what they secrete. We did talk about the factors that these cells release. We talked about the cytokines. We also heard about the SIRS and the CARS. The SIRS is a systemic inflammatory response syndrome, and the CARS is the counter anti-inflammatory response syndrome. So both were spoke to. What we need to understand is that we still don't understand whether SIRS and CARS come simultaneously. Do they come sequentially? Do they come to the same extent? To a certain extent, after SIRS, patients are left with CARS response that are so intense that they do have immunoparalysis. So thank you for taking us through it. You did talk to us in length about ulnastatin and thymosin alpha and touch upon the other immunomodulators as well. And you did tell us that with the available studies, both in ARDS and in sepsis, in the studies that you did look at, there has been mortality benefits with the drug as well. So we'll have to look at the evidence that is coming. Probably the eastern part of the world, therefore they have not come into bigger light or better recognition, but I think we need to focus on it and see whether we could use it to benefit our patients. Now, thank you once again. Now I invite Dr. Chakravarti, who's already started to share his screen, and he's going to talk about immune dysregulation and the therapeutic approach to use it in COVID-19. Let's now welcome Dr. Chakravarti. Dr. Chakravarti, please begin.
Good evening. Thank you, Dedipya. I think next 15-20 minutes, I'm going to talk about immune dysregulation in what is happening to in COVID-19 and what are the therapeutic options we have available so far, and from last 1.5 years, what are the options, various modalities of treatments we have tried to control this COVID-19. In due course of time, I'll discuss in detail. Okay. The main thing is there is a severe cytokine storm. All of you heard. Initially, the COVID-19 in the first 4 to 5 days will be viremia will be there, and then once the virus COVID-19 is taking affecting the human body, automatically the cytokine storm will take place, and the various immune dysregulation will start in the body. And to fight the virus, the body produces many kind of anti-inflammatory mediators. And when in the initial part of COVID-19, when in the month of January, February, March 2020, to know exactly what is happening with the COVID-19, it's any other flu virus, and retrospectively we have more data showing how the immunity plays a major role, and the thrombogenicity of the COVID-19 and the pathophysiology of COVID-19 virus, we have more idea. And we're going to discuss various parts of our SARS-CoV-2 virus, how it is going to cause immune dysfunction in human body. Exactly, the SARS-CoV-2 virus is having binds to the, all of you know, with the spike protein it has, and it is bind to the ACE2 receptors in the respiratory epithelium. And once it binds to the respiratory epithelium cells in ACE2 receptors, then various kind of inflammatory mediators were produced, that is IL-6, IL-1B, and TNF alpha. And there is a severe rise of cytokine levels in the body, and that leads to the severe cytokine storm. There is so much of cytokine mediator releases. Once the immune system is getting more and more active to fight with the infection, automatically the severe cytokine storm, there is so much of inflammatory mediators are releasing, they will damage our own tissues in the body. Mainly the tissue injury will happen, endothelial damage will happen, and that leads to mainly the affected part is the lungs initially, because the more number of ACE2 receptors will be there, and the virus is mainly entering through the upper respiratory tract, and it is mainly affecting the lung. That leads to classical ARDS like severe alveolar exudate, edema, and leads to severe ARDS in the patients. Then the thing is here, the targeting cytokine storm syndrome in critically ill patients, especially if any kind of, there are, as discussed in the earlier speaker, there are two kinds of mechanisms are there. Once the infection enters into the body, that is a pro-inflammatory phase, and once the pro-inflammatory phase is there, once the body is reacting to the pathogen, then automatically then immunomodulation will happen, and automatically the other things will, the innate immunity initially will take place. And one point of time where the homeostatic balance will be missed, then automatically the immunoparalysis will happen. There are various immunomodulators in COVID-19 has been studied. Among them, the first is non-specific immunomodulators, which is corticosteroids such as dexamethasone, methylprednisolone, and thymosin alpha, and macrolides like azithromycin, clarithromycin, HCQs, colchicine. These are the various immunomodulators tried in COVID-19, and other specific immunomodulators which has been tried are, one is our serinase protease inhibitor, ulinastatin, anti-cytokine monoclonal antibodies, various monoclonal antibodies against interleukin 6 antagonists like tocilizumab, or anti-CD6 biological like itolizumab. Many products are we are seeing in the clinical practice now to control this cytokine storm to avoid the host tissue damage. This is the again slide depicting of various products where it is acting in the immune system of to control the immune regulation. Mainly the corticosteroids will act on the immune regulators, and IVIG also acts on the immune regulators, whereas ulinastatin will act at the level of TNF alpha, IL-6, and it will decrease the interferon levels and IL-10 levels. Among all the immunomodulators, the first and foremost one where is well proven and is the corticosteroids. This is because basically the severe COVID-19 pneumonia is systemic inflammatory response, lung injury, and multisystem organ dysfunction. So corticosteroids is the mainstay of therapy still, and the monoclonal antibodies, we have various monoclonal antibody agents are available. Among that, the well-known product is monoclonal antibody tocilizumab. It is mainly targets the IL-6 receptors and blocks their action. It is usually mainly used previously in cases of rheumatoid arthritis. One second, there is something is wrong with this. Yes, thank you. It's okay?
Yeah, you can carry on, sir.
Yes, severe COVID-19 systemic inflammatory response. There is a lung injury and multisystem organ dysfunction. Mainly the corticosteroids play a vital role here with the anti-inflammatory effects of corticosteroids. This is what the recovery trial showed, that mortality from COVID-19 has lower among patients who are randomized to receive dexamethasone than the control group. Various corticosteroids have potential benefits in COVID-19. The first choice where they have tried in recovery trial is dexamethasone. The half-life of it's a prolonged half-life. It's up to 36 to 72 hours. Administration is once daily. And the other corticosteroids were well-known, methylprednisolone. Its half-life is 12 to 24 hours. Administered once daily or 2 divided doses. Or otherwise short-acting steroids like corticosteroids like hydrocortisone, short life of 6 to 12 hours. It is mainly recommended by the WHO for moderate to severe COVID disease of COVID-19, and the recovery trial, and it was well approved, and it was approved by the FDA and also European Medical Agency also. Next, please. The other modality of therapy is monoclonal antibodies. Among the monoclonal antibodies, the well-known tocilizumab, all of you know, it mainly targets the IL-6 receptors and blocks their action, normally used in the treatment of rheumatoid arthritis. The patients in the tocilizumab group are more likely to discharge from the hospital within the 28 days. Among those who are not receiving invasive mechanical ventilation, patients who receive tocilizumab are less likely to reach the composite endpoint of invasive mechanical ventilation. So overall, the tocilizumab definitely it will have its proven efficacy in mortality benefit. It included approximately 38% of mechanical ventilated patients. The trial did not meet the primary endpoint of improved clinical status in patients with COVID-19 associated pneumonia, or the second entry point of reduced patient mortality. But the trial did not show a positive trend in time to hospital discharge among patients who received tocilizumab. And especially those patients who have very rise in IL-6 levels, we have seen in our practice also, tocilizumab will definitely have a good control in regulating the cytokine storm. It is approved by the NIH and also UK. The The other monoclonal antibody that is well studied was anti-CD6 monoclonal antibody used for various cancers in moderate to severe chronic plaque psoriasis. It is itolizumab. The drug is now being repurposed for COVID-19. A phase 2 multicentric open-label 2-arm randomized study was conducted, and 20 patients were randomized to receive itolizumab plus supportive care, while 10 patients received only supportive care alone. The patients who received itolizumab recovered fully and were discharged from the hospital, whereas the 3 out of 10 patients were in the control arm but died. So there was also significant improvement in the key efficacy parameters, like all the inflammatory mediators they have proven, and the lung function PO2, FiO2, and SpO2 was also improved in itolizumab arm. So itolizumab is approved by the DCGI India for moderate to severe COVID-19 disease. Next. The other monoclonal antibody nowadays we heard about is bevacizumab. Bevacizumab is actually blocking the VEGF and VEGF receptor mediated signaling, improved oxygenation perfusion, and also anti-inflammatory response. It is mainly optimal dose for COVID-19 is unknown, but dosage of 2 arms they have studied. One is 7.5 mg per kg IV or a 500 milligram IV being studied in the clinical trials. This trial was done in China and in Italy also. And from February 15 to April 15, 2020, a single arm recruited 26 patients from 2 centers with severe COVID-19 and follow-up for 20 days. Relative comparable controls, bevacizumab shows clinical efficacy by improving the oxygenation and shortening the oxygen supportive duration. At present, ongoing clinical trial is happening in US, and bevacizumab severe or critically severe COVID-19 patients. This is the best RCT. Next. Other monoclonal antibody, that is the cocktail from Roche. Actually, we have very much popular now. That is the casirivimab along with imdivimab, and it's an antibody cocktail. It has been called an antibody cocktail because it is made from a combination of 2 monoclonal antibodies. And 275 patients either got 2.4 grams of Regin 2 or 8 grams of Regin COVID-2 or placebo. Symptoms cleared after 6 days, 8 days, and 13 days respectively. Patients who have not developed their own antibodies and had more of the virus in their body saw the most benefit with this Regeneron antibody cocktail. Regeneron reported that Regeneron CoV-2 reduced viral load and relieved symptoms sooner in patients with COVID-19 who were not hospitalized. So it is mainly the product monograph itself is describing that this antibody cocktail is recommended for the patients who are not hospitalized and the patient's oxygen level is not impaired, the lung involvement is not there much. But patients who are in high risk group, you think definitely the mortality chances will be higher. The patients are potentially very high risk group where the antibody response will be slow. Those cases it is recommended and is recommended by the FDA, issued in emergency use authorization, and also it is approved by DCGI in India. Now we are already we are using in clinical practice this cocktail. Next, please. Other immunosuppressant baricitinib, it is a JAK2 inhibitor as well as an AAK inhibitor that interrupts the passage of the virus into cells and can help prevent virus infection. Adaptive COVID-19 treatment trial recommended by the FDA granted an European Union Association on November 9, 2022 baricitinib to be used in combination with remdesivir for patients hospitalized with COVID-19 infection who needs an extra oxygen support or breathing assistance. Along with remdesivir, they have recommended, and our DCJ is also approved this molecule in 2021, and NIH currently recommended using baricitinib with remdesivir only if patients who have been contraindicated for corticosteroids. Definitely you can try along with remdesivir. That is the recommendation was given by NIH. Next, please. Till now, we have seen therapeutic options, steroids, monoclonal antibodies to modulate the immune response in critically ill patients as a rescue therapy, where the patients were admitted to the hospital who were requiring oxygen, and we are desperate measure to control the cytokine storm, to improve the multi-organ dysfunction state. The patient should not progress, to get the oxygenation level better, and other systems to safeguard. We are trying all these monoclonal antibodies. But as the monoclonal antibodies are in short supply, and when the peak pandemic in the peak, definitely getting the monoclonal antibodies is really a tough job, even in tertiary care centers also. So those molecules have a number of limitations because these monoclonal antibodies again will have immunosuppression. They have secondary bacterial or fungal infections, avascular necrosis, anaphylactic reactions, especially most of these immunomodulators we are encountering. And patients we have organ failure like liver failure, kidney failure, where the monoclonal antibodies are contraindicated contraindicated. We have other immunomodulators we are trying in clinical practice. Those we have already in practice is ulinastatin, thymosin alpha, etc. These products have shown their own benefit in controlling cytokine storm when used in a right time and dose in patients with critical illness patients. And we have tried ulinastatin, especially in case of moderate to severe pancreatitis, major trauma, ARDS, and severe sepsis patients. Already we have a good clinical exposure. Next, please. The ulinastatin is a broad-spectrum serine protease inhibitor that is currently available for the treatment of severe sepsis, ARDS, and mild to severe acute pancreatitis. Ulinastatin for the prevention and treatment of cytokine storm in COVID-19 we are using. Besides its effect on reduction in levels of TNF-alpha, IL-1 beta, IL-6, and interleukin-8 levels, ulinastatin has confirmed significant efficacy in removing oxygen-free radicals and also improving microcirculation and tissue perfusion and alleviating the endothelial injuries. Early introduction of ulinastatin in optimal dosage 2 lakh units IV TDS would be ideal in critical illness patients like sepsis and ARDS, pancreatitis, and also even COVID-19 sepsis. We can, next please. This is the experience of use of ulinastatin in H1N1 influenza. This was Infection International Journal. It was there. Corticosteroids should be used with caution since prolonged use of systemic high-dose corticosteroids could result in severe adverse event in influenza virus infected patients. However, low dose of corticosteroids may be considered patients with septic shock. Where there is adrenal insufficiency suspected, definitely we can use low dose of corticosteroids. Ulinastatin, instead a broad spectrum enzyme inhibitor, could protect pulmonary functions from being harmed by a variety of factors from extracorporeal circulation. In addition, the morbidities of stress ulcer, hyperglycemia, and fungal infection would be low after IV injection of ulinastatin. Furthermore, ulinastatin has shown promise in replacing glucocorticoids for clinical management of ARDS. Therefore, ulinastatin might be considered as an alternative treatment for glucocorticoid patients with severe critical illness H1N1 infection. It was the Journal of Infection. It was published for H1N1. Next, please. Yes. Other immunomodulators, in addition to ulinastatin, will be the thymosin alpha. It can prevent a pro-inflammatory cytokine storm by increasing the regulatory T cells. It is used for treatment of hepatitis B, C, and under clinical trials in USA for COVID-19. Study in 8 government-designated treatment centers in China in COVID-19 patients in intensive care and general wards in 3 cities, Wuhan, Yangzhou, and Shanghai. It was revealed that thymosin alpha administered could be significantly decreased 28-day mortality among critical type of COVID-19 patients. Moreover, thymosin alpha obviously attenuated acute lung injury as evidenced by improvement in PaO to FiO2 ratio in thymosin alpha treatment group. Next, please. In conclusion, cytokine storm is inevitable in critically ill patients with COVID-19 that we already have a good awareness, exposure, and experience with this COVID-19 so far. So immunomodulator therapy is cornerstone along with the antiviral and supportive care. Definitely, we have to accept this fact. Steroids are not alone enough in certain patients. Monoclonal antibodies has role to play when used judiciously, considering their safety issues, contraindications, availability, and other things. Based on our past clinical experience of managing similar critically ill patients, we are using already available certain drugs like ulinastatin and thymosin alpha. These drugs should be added to the moderate illness patients in COVID-19, where the patients are having other comorbidities, where potentially patients are going to develop the complications and multi-organ dysfunction syndrome to avoid landing up in. Definitely, it will have in these immunomodulators like ulinastatin, thymosin alpha. It has its own clinical benefit with less side effects, and we can use next. Thank you. Thank you so much.
Thank you, Dr. Chakravarti, for taking us through immunomodulatory therapies and their role in COVID. I think it is going to be very mundane for the audience for me to really mention what therapies we should use for COVID, because I think they are all very, very familiar with it. But just to summarize again, definitely we know that after the recovery trial, that results came up in the first week of June 2020, that dexamethasone at the dose of 6 milligram or its equivalent has a role and a mortality benefit for patients who are with COVID-19, especially those requiring oxygen. We clearly know that. We do have conflicting reports of tocilizumab. The recovery trial says, and then we have the other trial says that it may not have a mortality benefit, but yet tocilizumab is being used. The US FDA has not approved it, but the IDSA guidelines, you would still find the use of tocilizumab. We know that we use it 400 milligram first day when the oxygenation requirements, despite DEXA increase, and another 400 milligram if the first dose is not helpful after a period of 24 hours. We also find the use of baricitinib, the JAK2 inhibitor, and we know that we can use it at a dose of 4 milligram per day for about 14 days. That again, though it did not meet the primary endpoint, which was to decrease the hospitalization and the disease course, yet subgroup analysis seem to say that it was a mortality benefit. That's how it's found its way in use. However, people are saying that there are other trials of baricitinib which are going to be published where it may have a mortality benefit. So we are using questionable drugs of mortality benefit, tocilizumab and baricitinib, but we do find it. And of course, there are other monoclonal antibodies of which you spoke about, of which there is no sufficient data, and we're using it. And obviously, you also talked about the use of ulinastatin and thymosin alpha, and we need to look at the evidence for it. So nice for this wonderful summary. So we've talked about immunomodulation. We talked about how immunomodulation is very useful in sepsis and ARDS, and we looked at how immunomodulator is definitely useful in COVID-19. There's no question about it. Maybe COVID-19 has made us rethink about our strategy of how we have to treat our previously treated diseases that were killing people. So this is a nice stage for me to invite the other two panelists also. Welcome, Dr. Badri and Dr. Rohit.
Good evening, everybody.
Yes, Badri. Nice to have you here. And Dr. Rohit. Hello, Dr. Rohit. Can I hear you?
Thank you, Dr. Dilipia. Hello to all the panelists here.
So now I'm going to request Dr. Ponnaya, Dr. Chakrabarti to stay along with me while I'm going to ask some questions. I want all of you to come in and talk about. Now, let me begin with our first two panelists before I go to the speakers. Dr. Badri, before COVID-19, we're talking about pre-COVID-19 era. So we're talking about sepsis management. In addition to organ support, which you would do, in addition to of hydrocortisone that you would do for patients with septic shock, in addition to treating the infection with appropriate antibiotics, in addition to source control as indicated and antifungals if needed, did you ever consider the use of immunomodulator agent? Answer would be yes or no. If so, which of them? Was it based on any hardcore data? Is it your personal experience? And what do you think about them? So just these 4 points. Did you use them? What were things that you used? Was it based on hardcore evidence and your personal experience with the use of it? Can I have you, Dr. Badri, to enlighten on
for the opportunity? Yeah, even the pre-COVID times, I have used immunomodulators like ulinastatin. So ulinastatin has been in the usage for more than a decade, I suppose, and I have used ulinastatin in cases of sepsis, the so-called severe sepsis or sepsis with organ dysfunction, and also in patients with ARDS and patients who are with pancreatitis. So this is not just a trial-based usage, but based on studies, especially Chinese studies, which has been published a few years ago, and they have found that it modulates the toll-like receptor 4 and the nuclear factor kappa B pathways, which are very imminently involved in sepsis progression in the patient. So by which we strongly believe that ulinastatin could play a role in immunomodulation in patients with sepsis with organ dysfunction. So I have experience of using that. I have initially I have tried with 1 lakh units thrice daily, and there are studies using 2 lakh units thrice daily, as well as there is an Indian study also done by our Maharashtrian team, including Dr. Shiva Iyer and Dilip Karnad. They have used 2 lakh international units bi-daily. They have found that there is mortality benefit with ulinastatin that I have used. What was the next question, sir?
No, your personal experience, was it based on any particular person?
Yeah, it has been useful.
Okay. Other than statin, have you used any other immunomodulators other than corticosteroids?
No, no. Previous to COVID, we were not using any. I heard about activated protein C, but first I have not used it. But there has been do positive and minus results of protein C. Even though it
Don't
was
worry, you're in the post era. I was in the activated protein era. I never believed in the molecule, but anyway, we used it and gone out of disrepute. Yes, that was also
now it has been
immunomodulation.
removed from the market. I have not used anything else other than Urihk.
Now, from talking to you, I understand that you have used steroids, immunomodulators in sepsis on the evidence, and you also have that, and you have used it based on. I go to Dr. Rohit. Dr. Rohit, the same set of questions for sepsis management. Have you used immunomodulators? If so, which of them? If not, why have you not? Do you believe in them at all or not?
Yes. Firstly, thank you for this opportunity, Dr. Deep. In terms of immunomodulation in sepsis, the only use that I have used in my practice is the steroids as part of the surviving sepsis guidelines. And in terms of other immunomodulators, before the pre-COVID era, I don't have any experience of using other molecules. There was, like you mentioned, about activated protein C, probably 10 years back during my training when we used it for one patient on an experimental basis. But apart from that, pre-COVID era, steroids, and there was a phase when we used thiamine and vitamin C along with hydrocortisone to treat septic shock patients. But in my practice, I have not seen a great difference in terms of any benefit that it had given us. And the recent vitamins trial also has come out, which showed no mortality benefit in terms of adding thiamine and vitamin C to hydrocortisone in terms of septic shock. Of course, post-COVID era, I have experience in using the IL-6 receptor blocker, that is tocilizumab, along with the JAK2 inhibitor, baricitinib. And as you rightly pointed out, the evidence from the recovery trial and from the other trials also showed some mortality benefit that is there with this particular monoclonal antibody. So that is my experience that I have in terms of immunomodulators in sepsis.
Thank you for that very honest and very eloquent answer to this question. And I thank you for your for being very optimistic. You said post-COVID era. Oh my God! I just wish we are in the post-COVID era. I think we're still in the midst of
Probably.
and I wish your words come true. Okay, so let me surprise. You said that other than using steroids in the pre-COVID era, and other than using steroids in the COVID era, along with tocilizumab and baricitinib, you've not used other immunomodulators. You had considered the use of hydrocortisone, the hydrocortisone, ascorbic acid, and thiamine, but since there is lack of evidence, you wish not to use it anymore, and you used ulinastatin much in your practice at the present point of time, and that is possibly because of your training in the UK, where I don't think so. This molecule is much of repute as well. So that may be
in terms of usage. In terms of usage in Europe, there was not much exposure in terms of its use there.
So that you have come to India, we'll have to see whether you would change your opinion and look for more data as well. That was very nicely answered. Now I go back to my two panelists. I mean, two speakers. just a word. What are the immunomodulators that I've used, and why have you used them? If there's anything that you need to add to what the other two speakers have said, please go on ahead. Now I'm going to call on Dr. Puneya first, and then following him, Dr. Chakravarti can take over.
I think this is Dr. Vijay, sir. I think Dr. Puneya is disconnected. I'll just try it out. He may be having some technical, sir. We can have Dr. Chakravarti's opinion, sir.
Yeah. Yes, Dedipya. The thing is, am I audible?
Yes.
Yes, yes. Please continue.
Yeah, regarding immunomodulators, as the things what we have used earlier was definitely steroids as for surviving sepsis campaign part where there is a suppression of adrenal suppression. Definitely, steroids were there quite proven, and after this recovery trial in COVID, definitely we have to. Steroids have its definite clinical better efficacy. We have proven, and we have seen day to day. We are seeing in COVID. Steroids, that is the day-to-day practice. The second part is, as we told you earlier, the monoclonal antibodies. The monoclonal antibodies also definitely depends on the particular patients, where if the patient is in real cytokine storm, and definitely the IL-6 levels are very high. And to combat the cytokine storm, definitely we have used these monoclonal antibodies. We have used itolizumab, I have used tocilizumab, and but I've heard about bevacizumab, but I have not used it. And these molecules definitely, when we use in the right patients, definitely in bedside clinical improvement, we have seen there is a good number of improvement, and we have
pre-COVID. We are talking about pre-COVID. I'm sure these were not available COVID. So what are the they've used?
Pre-COVID era means definitely one is steroids. Second part is we have used. I have not vitamin C. I have tried before, but I have not much. I have not convinced about the data also and about the efficacy. And thiamine is also the same. The other molecules, like as I discussed now, the urinastatin. Definitely, urinastatin, we have used in the pre-COVID era, especially in cases of where the SIRS response is too high. Classical example is non-infective, it's mainly in pancreatitis. In moderate to severe pancreatitis, we have used in patients, I've used and I've seen the clinical benefit also. And the other part we have used urinastatin is patients who are in septic shock, where the vasopressor requirement is very high. And we have seen in a good number of cases the requirement of vasopressor has come down after using it's because of immunomodulatory effect of urinastatin, and mainly it's immune regulation and how it controls the TNF alpha and other inflammatory mediators. We have seen, and other than the thymosin alpha in COVID era I have used, but not in the pre-COVID era.
Okay, so are we having Dr. Puneya or have difficulty connecting with him?
We are trying, sir. We are trying, sir.
So let me just summarize what our panelists said. Dr. Badri says he's used steroids and he's used urinastatin, and he's used urinastatin in 1 million units TDS for about 5 days and used it in patients with septic shock and ARDS, and he finds that it is useful, and he believes in the Chinese and the Indian data to support his usage. Dr. Rohit feels other than steroids, he doesn't use any immunomodulation at this present point of time, reflecting his training as well. And then Dr. Chakravarti says he's used it for pancreatitis, he used it for severe septic shock. Yes, definitely we also have to talk about pancreatitis. No questions asked. Urinastatin has had a role, especially in pancreatitis associated with ERCP. So the usual trend is to give urinastatin prior to an ERCP, and that reduces, shown to reduce mortality as well in some of the studies. So that is practiced by gastroenterology centers as well. So we finished our first question. The second question is best time to initiate immunomodulation. I'm going to ask Dr. Badri to answer this question. Best time to initiate immunomodulation. So for your patients with septic shock, when do you consider immunomodulation? Best
So
time.
yeah, I feel that immunomodulation should be started as early as possible. When you see there is a rise in the inflammatory marker, I frankly to say, previously that is even before COVID or during the COVID times, we were analyzing the biomarkers, waiting for the results, and starting it. But of late, even before the markers arrive, we go more clinically. The patient suddenly worsens, or there is an increase in oxygen demand, or the patient requires high oxygen therapy. We start immunomodulatory therapy. That is the current trend I follow in my hospital, frankly to say. But I feel that to substantiate it, there must be an increase in the uh, acute phase reactant level also. But many times we find that the interleukin levels are not up to the mark to warrant the use of monoclonal antibody, especially tocilizumab. But based on the clinical evidence and clinical experience, only we go nowadays to use the immunomodulator therapy.
Okay. So I think the best time to use immunomodulation for in the COVID era, I think is very, very clear. Now, since you are using ulinastatin, I'm just asking you, in which patient would you use ulinastatin? Is it in all patients with sepsis, the diagnosis of sepsis? Uh, if not, is it in a subset of patients like septic shock requiring so much ml of noradrenaline, so much mics per kg of norad, or I mean, how do you decide that? And which is the time? Which is the time?
Yeah.
We just talk about
So
sepsis 19. We'll talk about later.
yeah. So patients with sepsis with organ dysfunction who have elevated C-reactive protein or procalcitonin, I consider immunomodulator therapy. Regarding steroids, I used not basically as an immunomodulator, but to substantiate the shock who are receiving high dose of vasopressors in order to provide the stress dose of corticosteroids. Ulinastatin I have been using in patients who have organ dysfunction and who have increased acute phase reaction parameters.
Now, will you choose it in one organ dysfunction, two organ dysfunction?
Yeah, even in one organ dysfunction, if it warrants, yes.
Okay, so any patient with sepsis in the ICU, you would use ulinastatin. Am I left to understand that? Okay.
Yes,
Okay.
yes, sepsis with organ dysfunction, yes.
Septic shock, obviously, which means in septic shock, you will use that.
Yes, yes,
Right?
I definitely
Yes.
use it.
Yes. Okay. Okay. So the timing. Do you mean to say that if a patient comes with sepsis and low platelets, which is an organ dysfunction in sepsis, you would start ulinastatin in him right away, or you would wait?
I would like to wait and see what is the exact cause for thrombocytopenia, whether he has been on any drugs previously, or it is a drug-induced thrombocytopenia, or previously there is a history of thrombocytopenia. Evaluate and then start on ulinastatin, not right away on the day of admission.
Organ dysfunction. So first organ dysfunction that you'll talk about maybe platelet dysfunction. So platelet dysfunction, you will verify whether sepsis is the cause. If you think sepsis is the cause, you would start ulinastatin. Okay. Sepsis with one organ dysfunction with say increased creatinine. Sepsis with AKI, not in shock. Maybe urosepsis uh, with AKI. You will start ulinastatin.
And that is really a tough because in renal dysfunction, I have not seen any studies which was denied the use of ulinastatin in renal dysfunction patients. I would like to take an opinion from the nephrologist as well, whether it needs a dosage adjustment, and then I will start ulinastatin.
Okay. So what I understand is that when you have organ dysfunction, which is the definition of sepsis,
Yeah.
start any patient with ulinastatin, and you already mentioned the dosage, and obviously you'll use them in septic shock as well. So I'm
Yes.
going to go back to Dr. Chakravarti and ask, what is the time? You said you also have used ulinastatin. You used it in patients with ARDS and septic shock. Forget about pancreatitis. We're going to focus on ARDS and septic shock. When do you use ulinastatin? The best time in which you use this as an immunomodulator?
Ulinastatin we'll use in sepsis when there is any organ dysfunction, requirement of vasopressor support is there.
Okay. So single vasopressor you will still use?
Yes, if it's high dose, In the sense, it's maybe if the vasopressor requirement is steadily going up more. Even though after source reduction or something, the correctable factor is there, even then the vasopressor requirement is going up. If you feel it's mainly because of the inflammatory mediated response is driving the problem, then definitely I will use it.
Okay. Now, should I just, am I left to understand that if a patient
Yes.
comes to your ICU and is in shock, you would start antibiotic, look whether there's a possible source control, you will give
Yes.
fluids, you will start them on vasopressors, you'll start them on hydrocortisone, and then wait for a period of time. And if you find that there is an increase in the requirement of vasopressors, you would consider using urinastatin. So that is the practice. So
Exactly.
how long would you wait? That's my question, because for the benefit of the audience.
Exactly. How long? It's maybe depends on the patient stability. Maybe yeah.
You may say
Uh,
I personalize. So I'm just saying, how early have you used and how late have you? That's the question I'm asking.
I think late, maybe early in the 6 hours time, or maybe 6 hours to 12 hours of admission, definitely. In the initial
Okay.
6 hours, 12 hours admission, definitely.
Okay.
Yeah.
I'm staying on with you. Any other available option of immunomodulation that you've used? Yeah.
As I told you, other immunomodulators, as I told you, vitamin C I have used and seen, no, and thiamine, not much, and maybe
Minute.
immunosin alpha in COVID I have seen. Yes, I am using.
So I'm talking about non-COVID.
Non-COVID, maybe that's all. I have not used any other thing other than this.
Okay. I'll go back to Dr. Rohit. Dr. Rohit, I understand that other than steroids, you've not used much of any of the other immunomodulators, definitely not urinastatin. Have you used any other immunomodulatory agents? You did talk
So
about
I'd like to add
and
that
thiamine.
the
Any other have you come across in your practice while you were in the UK?
the granulocyte monocyte CSF that we use quite often in neutropenic patients does contribute to the class of drugs that we are talking about. So that we are immunomodulating to some extent there, especially neutropenic patients. So definitely there is good enough evidence to use both the granulocyte monocytes colony stimulating factors that we commonly use in these neutropenic patients particularly.
Okay. So other than setting of neutropenia, in non-neutropenic posts, have you used GCSF or GMCSF?
Not in non-neutropenic patients who don't have any sort of immune paralysis in terms of their neutrophil count as such. I'd just like to add a point, if you don't mind. In terms of ulanastatin, with regards to the evidence and the meta-analysis that was conducted by Liu and Zhang about these Chinese trials along with the 2 Indian trials, which showed the all-cause mortality benefit. So I think the average duration of their usage of ulanastatin in sepsis was early in the detection of septic shock itself. So if you cohort of their patients, it was all mostly sepsis, early sepsis who were hypotensive, having organ dysfunction. And like Dr. Badri said, in terms of kidney dysfunction, there wasn't enough data to show us what cohort of patients they had who had AKI on presentation when they started the molecule. So all the 13 studies that you see in that meta-analysis showed an all-cause mortality benefit, although they were underpowered in terms of the number of cases recruited. So there is a latest ADAPT trial that is ongoing now in China. That is a multicentric study with more number of patients and better power. So we probably await results of that in terms of septic shock and the use of ulanastatin. And like you rightly pointed out, in terms of usage in pancreatitis, Dr. Divya, there is definitely evidence to show that in ERCP-induced pancreatitis, there can be some benefit in terms of using ulanastatin prior to the procedure there. So In terms of immunomodulation, yes, the GM-CSF in neutropenic patients would be the other use that I've used immunomodulators in.
Okay. Thanks, Dr. Rohit. I know you're waiting for the ADAPT trial to come out before you recommend using ulnastatin in all your patients. Thanks for that. Now we are just going to talk about. We've talked about immunomodulation. We talked about benefits of immunomodulation. We do have seen the benefit of glucocorticoids in patients with COVID-19 and undoubtedly hydrocortisone in patients with septic shock. No questions asked. We have talked about the use of ulnastatin, thymosin alpha, the ascorbic acid thiamine, the studies as immunomodulators, and we've also talked about the use of tocilizumab and baricitinib in patients with COVID. Now, the question is, now with the rise of fungal infections like mucormycosis, we know there is a very, very high incidence of mucormycosis that has been reported. Previously, hitherto unreported. Now, why is it so? We still do not know. We are puzzled. Some people say it is steroids. If it is steroids, then why was it not seen in the first wave where steroids were definitely used and used crazy as well? We continue to use them crazy. But in addition, in the second wave, we've used more of tocilizumab, we've used more of baricitinib, we've used more of the other monoclonal antibodies. Now we have the risk of mucormycosis. So now, in terms of mucormycosis and immunomodulation, which of these patients are you using them, and would you have a reservation of using them because considering that there is a risk of mucormycosis? I'm going to go with Badri, then with Dr. Ponaya, Dr. Chakravarti, and then Dr. Rohit. So, which immunomodulator will you use in considering that there is a risk of mucormycosis?
Frankly speaking, I have not encountered any case of mucormycosis till now in our hospital, at least developed in our hospital. But we have seen patients admitted with mucormycosis coming from other hospital, probably post-COVID treatment, all those things. And we didn't go to that level of immunomodulated treatment in patients with mucormycosis. It was basically a conservative management, and we had to refer one or two.
If you use an immunomodulatory therapy and the patient develops mucor, you are questionable.
Okay.
Is it not? So, which of the immunomodulatory therapies would you not do? Do you think ulnastatin will increase the risk of mucormycosis?
No, I think steroids only can increase so far, because we have been using ulnastatin as well, but we have not seen a case of mucormycosis associated with ulnastatin. There has been no studies also.
Antibodies could have also been playing a role in mucor.
Yeah, may have been, but due to rampant use of steroids compared to monoclonal antibodies in various centers in this time, I feel more it is associated with the steroids rather than the monoclonal antibodies.
Okay, so steroids misuse you think is the cause of mucor. You think monoclonal antibodies can also cause mucor. You don't think so?
Yes,
Ulnastatin can cause mucor. Yeah, it's a serine protease inhibitor. I think the pathophysiology and the biology of the molecule seems to suggest it may not cause it as well. Dr. Chakravarti, your comments?
Yes, mucor. Yes, there is so many cases I'm seeing. Initially, in first wave also we have only one case of mucor I have seen. One elderly man treated with COVID, treated in our center, discharged. The patient is again come back and admitted. Then we found mucor and we lost the patient. That is one case I have seen in the first wave, entire first wave. But I don't know why in the second wave there are so many cases of mucor. Initially, we have cases receiving from the other hospital. Then we have our own hospital treated cases. We have seen mucor. Early mucors we are able to identify right now. Any patient is coming with hemifacial pain or some kind of tooth pain, face, some kind of vague symptoms also we are doing, and we are identifying CT and MRI, PNS, and our radiologists and ENT surgeons are telling that the bone, little bit the sinus, also they're able to identify early cases. Even then we're doing convinced that it's mucor, and then we are taken for debridement. After histopathology is growing the mucor, and definitely we have proven the cases of mucor. Definitely mucor cases are more. But the reason why the mucor is more rampant now in the second wave and it was not there in first wave, still I am doubtful. And people are telling steroids or monoclonal antibodies are responsible for it. But I feel one thing I convince is patients who have high HbA1c, uncontrolled diabetics, exposed to COVID is one reason I feel. The other thing, maybe if you can see, I have one patient in COVID ICU right now. That lady is a CKD on conservative management, COVID. Other family members become COVID positive. She's exposed with RT-PCR negative. Then she becomes sick, brought to our hospital with facial pain. She neither exposed to steroid, nor to monoclonal antibodies, or neither she is a diabetic. That lady has a mucor now. So that case I have seen. So I don't know really what really monoclonal antibodies or steroids alone culprit for this mucor, or is it the strain itself is responsible for it? I am doubtful about it.
So will you use ulnastatin or not use? Do you think it will have an effect on increasing mucor?
I don't know really. I don't think so. Why should it be responsible to have really?
So you don't think so? It will be. Yes, the biology didn't suggest that. Okay, Dr. Rohit, I think you're seeing a lot of mucor as well. Other than what has been told, do you think there's any other attributable risk factor for the development of mucor? People have said it could be diabetes, it could be badly controlled diabetes, it could be DKA, it could be the use of inappropriate dose of steroids, it could be the combination of steroids with a monoclonal antibody, or it could be the COVID-19 as well. And to add, I think it's the oxygen. I'm not sure how much of us have used industrial oxygen. We never know the source of the oxygen, considering the oxygen scarcity that happened, whether the medical oxygen was mixed with industrial oxygen, whether that's the source, or is it the COVID-19, the Delta variant, which can predispose and cause co-infection? I really don't know. Do you have any other?
You're spot on in the terms of what the other possible causes or explanation could be there for why we are seeing such a high incidence of cases here, specifically in the second wave. Because I was partly experienced with the second wave in the UK as well, where the cases were very high. Despite the cases being so high and the steroids used quite extensively there, they didn't have that many incidences of mucor as such, or because everything is audited there and it's a little more stringent. So I think it's probably down to the latter 2 points that you mentioned about our lack of oxygen that we were struggling with in the peak of the second wave, use of industrial oxygen. We don't know how much of impurities were there. We know mucor is a fastidious organism that is present quite extensively, especially in construction sites close to our hospital sites, and the exposure is easy. Apart from that, our Delta variant also being involved in severe immune paralysis, probably causing more susceptibility to the fungal infection itself. Apart from blaming the good old steroid and putting everything down to unscrupulous use of steroids. Of course, steroid use should be used in a proper manner, but even our diabetic population also can be contributory to the fact that we are seeing more cases. But I think it's definitely multifactorial, and I think this has a big role to play in our country, where we had this crisis and there was no such the ability to maintain that quality of care that we were giving our patients. It was not possible with the sheer numbers and with the oxygen shortages, apart from the variant itself being so virulent.
Sure. I think this question has been answered by Dr. Badri. The dosage and duration of immunomodulators like ulnastatin and thymosin alpha is going to ask. He's answered that. He says he'll start 1 million units three times a day for about 5 days, and he's not used thymosin alpha. And I know Dr. Rohit has not used either, so I'm not going to ask him. I'm going to now go to Dr. Chakravarti. The dose and duration of ulnastatin, and if you use thymosin alpha, that as well as an immunomodulator agent in patients with sepsis, septic shock, and ARDS. What is the dose? I know that you use it personalized based on their increasing vasopressor need, as
Yeah.
you told early. What is the dose and how long do you use, and when do you decide to stop?
Illunastatin, we used to use 2 lakh units IV twice daily, 5 days.
Okay. So, my question is, suppose the patient is weaned off vasopressors in day 2, day 3. Still, do you continue them for 5 days or you stop them?
Oh, stop it. I'll stop.
I'm going to ask you another question. If the patient continues to require vasopressors beyond 5 days, will you continue it beyond 5 days or will you stop them?
Then also I'll stop.
Okay. I think Dr. Badri was using 3 million units. You are using 4 million units. So roughly that seems to be the practice. Both of you agreed upon the fact that you use it for 5 days and you will stop here if your vasopressors came off. But if you still vasopression was vasopressor dependent beyond 5 days, you will think that he's not benefiting from it and stop the agent as well. And do you have any benefit? Any insight in the role of thymosin alpha? You personally use them. You've discussed with people who use them. Do you think you want to share anything about it or no? Thymosin alpha. No.
Thymosin alpha, I'm using in the COVID era. I'm using it actually, and I'm using 1.6 mg for 5 days, and
Okay.
I've used, but mainly patients who have been corticosteroid cannot be given. The sugars are very erratic high. Those patients, especially, I'll choose to give other immunomodulators.
Okay. Okay. What's the cost of thymosin alpha?
Maybe around 1 day cost, maybe 1.6 mg may cost around 2,500 rupees to 3,000 maybe. I think exactly. I didn't remember the exact rate. Maybe around that range. Maybe around 2,500 rupees to 3,000 rupees.
Okay.
Maybe 5 days is almost like 50,000 rupees.
Okay. 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 So I think you have some questions from the audience as well. So I'm going to Dr. Vijay, can you just help me with those questions? Can you just read out those questions? I'm unable to see them in the chat box.
Yes, sir. Yes, sir. Absolutely. Sir, we have a first question from Liangon, Chennai, who is asking about the immunomodulators and risk of fungal infection. And I think this has been addressed already, sir. The risk of fungal infection and the use of immunomodulators, sir.
Okay. So, any other questions come up?
Sir, I'll just allow me, sir, 2 minutes, sir. Sir, Dr. Muhammad Arafat from Tirunelveli is asking about the adalimumab and what's the experience of the faculties with regards to the adalimumab, which has been used in some centers, as per his opinion, sir.
I have not used adalimumab. I've used only tocilizumab and I've used baricitinib. That's what Dr. Rohit also said. He's used,
Yes.
and I think Dr. Chakravarti has used adalimumab. Is it not?
I use itolizumab. Mainly I've used anti-CD6 inhibitor. I've used itolizumab, but adalimumab I have not used.
Okay.
And
None of the existing
yes.
faculty have used it, but we know that people have used it. But if you're asking me, we don't have any evidence other than the 2 monoclonal antibodies at all. If at all we have evidence for tocilizumab and we have evidence for baricitinib. Even the evidence for baricitinib is of today is quite weak. But maybe for tocilizumab, after the WHO trial, the solidarity trial said not to use it. The recovery trial seems to suggest that we would use it, and therefore tocilizumab is used. But otherwise, for the other monoclonal antibodies for COVID, we do not have any great evidence for its use. However, in the absence of a recovery with the conventional therapy, with the absence of the other monoclonal antibodies, either due to shortage or non-availability, in the presence of a sick, deteriorating patient, where there's no other option, as a desperate experimental measure, whether they could be used, I think that is left to the personal physician's choice after informed consent with the patient. I think possibly may be justifiable in use, but there's no great evidence as it is of today. That's what I would like to share to that wonderful question from one of our panelists from Tirunelveli. Any other question, Dr. Vijay? Sorry that I can't see them.
Sir, there is one question coming from Dr. Prakash. He wants to know what's the best time to introduce the immunomodulators.
Best time to immunomodulators. So I asked the panelists what they did.
Yeah.
Badri said he would use it whenever there is sepsis and organ failure. In API, he said he may not use it, or he may get an opinion of an nephrologist before he starts using it, but otherwise he's going to use it upfront. Dr. Chakravarti says he will use it in patients with septic shock, and you'll use it on a tailoring basis depending on when there is an escalating need for the same. That's what we said. But to answer it, I don't think so. We have a particular timing in terms of a rigorous study that is conducted. I think the timing and the need for it, first, the questionable need for it has to be addressed, and the timing of it has to be addressed. I think the trials that are coming from China would try to address this particular question. Otherwise, I think it is left to the individual person's perspective of how to use it. Obviously, in a patient in whom you've done all important things that need to be done, that is antibiotic appropriate source control, fluid at least 15 to 20 ml per kg that has been given, vasopressors has been started, and you've initiated mechanical ventilation in terms of respiratory support. If the heart is involved, you've started vasopressor therapy in case the hypotension is present, and you've added hydrocortisone. Then, and you think that you have to use ulnastatin or thymosin alpha, there may be a case in point. But I think the reason why most of these are not being used so much is because the data is from the East. When I talk about East, Far East, that is Japan and China. And when you look at Japan, you know, it's a very close society. They publish within them and do extensive research and publish in their language. And so much so with China as well. And a lot of skepticism from studies that are coming from China. So I think that is what is probably limited our knowledge and understanding, and probably the usage of ulnastatin. If ulnastatin were a drug to be developed from the West, I think usage would have been much more. So I think we have to rationalize, use it in appropriate patients, see it is, but not continue to use it if you think it is not benefit. But if it is a benefit, I think we should offer it to other patients as well. I think there is a need for studies. We do have an Indian study, but we probably need more studies that can be done for it. I'm not sure whether ICMR would be interested in funding such studies. So I think until then, we need to know that immunomodulation is very, very essential. Other than steroids, I don't think so. We have any immunomodulation that we're currently having evidence for the usage. I'm talking about sepsis. I'm not talking about COVID. For COVID, of course, we do have the monoclonal antibodies. For sepsis, no. Whether we could or should use ulnastatin or thymosin alpha has to be evaluated by studies. But there seems to be a biological plausibility of usage of the same, which has to be approved by large center studies. So we've looked at the experience of 2 panelists who have used it, and 1 panelist who thinks that he'll wait for more evidence coming from China before he uses. That's where we are. Any other questions that we do have?
No, sir. There are the repetition of what we already discussed, sir.
So if so, I think just before to conclude, I think we had a wonderful session with Dr. Ponnaya, Dr. Chakravarti, and looking at the perspectives of Dr. Badri and Dr. Rohit as well. Thanks for putting us all together on this platform to discuss immunomodulation in COVID as well as in sepsis and ARDS. And again, bringing into perspective, I think if not for COVID, I think immunomodulation will still be taking a backseat. I think because COVID-19 came, we now realize how immunomodulation is very, very important. And we realize that immunomodulatory therapy is possibly more important than the treating of the infection per se. Because we're talking about COVID, we clearly know that the use of remdesivir is not very useful in these patients. So much so that the Ministry of Family and Health Welfare have come up and saying don't use remdesivir indiscriminately. So remdesivir is an anti-infective or antiviral agent, but we have approval and mortality that we've seen in using immunomodulatory agents like dexamethasone or methylprednisolone or any other steroids in the equivalent dose of 6 milligram dexa, and obviously with monoclonal antibodies as well. So immunomodulation is what is being used in COVID-19. So maybe we need to have a rethink of those strategies for our patients with sepsis, septic shock, and ARDS as well. And therefore, in the context of the sepsis 3 definition, which has brought in and refocused the host dysregulated immune response, maybe we need to focus more on the immunobiology of sepsis and look at the immunomodulator therapies. The immunomodulator therapies that are currently available in India are ulanastatin and thymosin alpha. We've listened to the balanced viewpoint of 2 of our panelists who say they've used it, and 1 of our panelists who says that he would wait for evidence before he will embark upon it. And we know that evidence is on the way. And these 2 panelists have told us that they will use it somewhere between 3 to 4 million units per day in patients with septic shock and ARDS when they think the patient is not responding to conventional therapy, and use it judiciously to see whether they have a response. So that is what is the experience of the panelists here. Thank you for having all of us here. It was very nice. Thanks, Dr. Punish. Thanks, Dr. Chakravarti. Thanks, Dr. Rohit and Badri, for making it very, very enlightening. Dr. Vijay as well. Over to the organizers for their concluding remarks. And
absolutely, sir. Thank you, Dr. Dedipta sir, for wonderfully conducting this meeting and bringing out the important aspects of management of COVID and other critical illnesses. We as organizers very much blessed to host this program in collaboration with all the eminent clinicians from Chennai. And this program was brought to you by our flagship scientific program, that is the Advocacy for the Immunomodulators in Critical Illness, the AIMC. So our endeavor is to make sure in the right kind of patient, the immunomodulators like ulanastatin, thymosin alpha, or steroid for that matter, should be utilized in the management, not only in the COVID, but beyond COVID in sepsis, ARDS, pancreatitis, wherever there are hyperinflammatory responses. One should not have the hesitancy to use the immunomodulators in such suitable patients. And with this, I like to thank all the faculties for their wonderful depiction of their thoughts during the panel discussion. Dr. Chakravarti, Dr. Puneya has beautifully presented their talks. And I hope the delegates who were part of this program throughout has benefited by the session, and we'll look forward to organize such meetings in future also. And with this, I conclude the session and thank you very much.